Hello, good afternoon. I am Dr. Bhavesh Vajifdar, interventional cardiologist from Mumbai at Lilavati Hospital, and today we are going to discuss about the transradial procedures. I have been fortunate to learn transradial procedures from the father of transradial program, Dr. Ferdinand Kimenai at Amsterdam, the Netherlands. And I started doing transradial procedures right from the year 2000. And with me, I have another senior colleague, Dr. S.K. Chugh. It's a pleasure to have you here, sir.
Thank you.
And Dr. Chugh is the professor and head of department of the Jaipur National University, and he's an excellent interventional cardiologist. Importantly, he has been doing transradial procedures from the year 1997 when he first trained for the transradial approach at Toulouse in France. So Dr. Chugh, can you take us through your story, which perhaps will reflect on how transradial started in this part of the world? So can you tell us something about this?
Yeah, 1997 I was at Toulouse and I was trained by Jean Fajade, Jean Marco, and in those days radials had just started, and France was very actively involved in radials, and I was actually working as a registrar in cardiology in London, and I went there, and then after a few months I came back to the UK, met Dr. Jim Nolan, and he's a pioneer in the UK. In those days it used to be 2% in the UK. Transradials were only 2%, and there was a lot of opposition even there,
Yeah.
And then subsequently I had the opportunity to work in Canada. I worked at Victoria, which was a fully radial center, and I was amazed to see that, everything was being done radial and hardly anybody knew about that center. So coming back to India was like coming back on a time machine, and there was hardly any radial here. I met with Dr. Tejas Patel, and maybe one or two other guys were also doing radial at that time. And slowly, we started building on our radial experience and
Yes.
Teaching people about radials, doing radial courses. We started this Radial Live, which we still do. And this year it's going to be in 2019, 3rd February at Samrat. This year it's Chip Radial.
Wow.
Chip Radial at Radial Live. And the interesting story is, when I came back to India, we were scared that, if we failed, we would not be allowed to do, because as it is, there was so much opposition. And so to be precise and accurate, we started doing sizing of the radial arteries, and then we started looking at the Doppler to make sure the radial was patent when we got into it. We sized our hardware accordingly. Then we started looking at the cubital fossa to see if the bifurcation was normal, so that if we found an anomaly, we would cross over to the other side beforehand. It would be like a pre-selection, pre-procedure selection. And that sort of became a theme with us, and we still do that sizing, although I don't look at that data at all.
So do you still advocate, because we do not do a radial ultrasound before doing a radial procedure?
Well,
like for us, every patient, unless...
You see, right now we are collecting data, although I don't look at the sizes, but the data is being collected to see if it actually made a difference to our practice. But I think it does make a difference when you are in your early days. And clearly, when I trained on those bigger arteries, in the Caucasian arteries, the Indian arteries are much smaller. The average Indian artery, radial artery, is about 1.7 to 1.8 millimeters. And most of the radial arteries in the Western world are 2 millimeters or more. So clearly it was a bigger challenge, and we did not want to fail. And so fortunately, we got a very good publication out of this, and we are kind of leaders in this, in measuring the radial artery, doing a pre-procedure ultrasound. This was published in Cath Cardiovascular Intervention in 2013.
Right.
And that was the first sheet sizing protocol which got published. And today, as you know, people are going back to it when they have to use bigger size sheets. 7 French, they still use that to make sure that they are not overdoing it, because all these instances of the avulsion of radial artery and all those kind of things happen when you stretch it too much. And of course, the spasm begets spasm. So when a patient walks into the cath lab and you see it's a short-statured lady, you know that the radial artery is going to be small. So the hazard of radial artery spasm is going to be higher. So you want to know which is the biggest artery. It could be a radial or an ulnar. So if you have the measurements, at least in that subset, you'd be able to preempt any possibility of getting into spasm and crossover or failure. So that sort of becomes an advantage in select cases now, even in our today day-to-day practice.
So tell me, since you are talking about spasm, in fact, of course, as you rightly said, the smaller artery, more chances of spasm. But sometimes we also see in very large guys you get spasm, and that those spasms in huge guys are more difficult to treat. So can you tell us how you prevent a radial spasm, and then if it occurs, how do you tackle it?
You know, I think the important thing is you don't want to, let's start with the puncture. I think the puncture should be the best, the first puncture is the best puncture.
Yes.
If the patient is anxious or having pain, I think we need to preempt that. You shouldn't wait for pain to develop and then start treating, because by then spasm has started, then spasm begets spasm and it keeps getting worse.
Right.
So we have our own spasm grades, which was published in Cath Cardiology.
Yes, I remember reading that. Yes.
Yeah. So so grade 3 is when you have to pause, and grade 4 is when you have to cross over. So I think it's important to keep all of them below grade 3. So when the patient walks in, you know, if the patient is short, could have a small radial. If it's a bigger guy, you know if he's anxious or not, so you pre-treat that. If he's having pain, then you pre-treat that with, we use midazolam to pre-treat anxiety and fentanyl for pain.
Right.
And then the first puncture is obviously the best puncture. And then obviously the hardware that we use, we shouldn't overstretch it. So if it's a short guy, you don't want to use 7 French straight away unless you have an idea of size. And then not too many exchanges. If you do too many exchanges, the chance of getting into spasm is more. So I think you can actually look at the guy and say, the short guy, you would probably need smaller curves.
Right.
So I would use a shorter curve catheter rather than use a bigger and then exchange.
Right.
But if the patient has aortic regurgitation, has a large aorta for some reason, then you need a bigger curve. So that kind of mindset is important, so that you minimize the exchange and minimize the risk of spasm.
So as you rightly said, the most important thing is prevention, and as you said, anxiety is one very important factor, and you try to keep the person at ease, and you try to keep the pain to the minimum. Along with that, I think one more important factor is the patient being underhydrated. So if you have a person who is fasting for a long period of time, and if he has been on diuretics, and if he is hypovolemic slightly, then do you think these patients are at a little higher chances of getting a spasm?
Yeah, because you would have difficulty puncturing, and so when you poke it 2-3 times, you've initiated that vicious cycle of spasm.
So how long does your patient fast prior to a radial procedure?
All of our fasting patients get intravenous fluid, which is managed according to the left ventricle.
But if suppose a patient is at 2, would you fast him from overnight or morning 11?
No, we give them light breakfast in the morning.
Yes.
We allow them hydration, and we also maintain intravenous fluids to prevent getting into that problem of, and then often they drop their pressures post-procedure. Some of them will have vagals, and some of them are sitting propped up. They would go into hypotension. So, we preempt that by giving them adequate fluids.
Right. It's very important because we give a lot of vasodilators to these patients, and in fact there is a lot of discussion about what kind of a cocktail to use for preventing a spasm. And I remember when I was working with Dr. Kimnai, we had a couple of publications where we used to have a machine pull back the radial sheath, and it would measure what kind of force is required to remove that. And then based on that, we made recommendations of whether to use NTG or Dilzem or what kind of a sheath. So I think it still is very important to...
Yeah, in our practice, we always use diltiazem. Nitroglycerin is only in select cases, the pressure is good. And if you think that there's more trouble, more spasm than what you would anticipate. But usually it's 5 milligram of diltiazem. And what we do is, once the sheath is in, we give that. And with every exchange of catheter, we give diltiazem. Again, at the end, once we've removed everything and the case is over, we again give diltiazem. So that has sort of kept the, I think it's helped the patency rates as well.
Right.
And, I think let's begin with another important aspect, which is forearm hematoma.
Yes.
I mean, I haven't seen a compartment syndrome in my practice of more than 16,000 cases, but then these are reported, and I think it's important to be very aware that what kind of hemostasis do you use in your practice?
Right. So I think forearm hematomas to some extent are a little common. Discoloration is very common, but compartment syndrome or something really has it, I think, is almost like negligible. Because as you rightly said, even I think in the last 18 years, more than maybe 13,000 patients, and we have not had a single patient with compartment syndrome. So I think, of course, if it happens, it could be dangerous, but I think we need not worry too much about it. The kind of hemostasis which we use has been somewhat similar since we started in 2018, because still the favorite hemostasis is just by putting a pile of bandage which is put into a bullet form and put your elastoplast bandages across it, which has been going on for years. But of course now we know that if we overdo the compression, then you could have a slightly higher chance of a radial occlusion. Of course, it being subclinical, we really don't bother too much. But now we have so many devices which we use, like we use the TR bands from Terumo, we use the dial kind of a flow which is from one of the companies.
When I came back to India, 2002, I brought along with me one of those clamps that we were using in Victoria, because in those days there were no devices. And so initially I started also develop the program at Bikaner Medical College, and so we used to take the clamp there and do, because one of those occasions I forgot to take the clamp, and so we managed with the bandage, and ever since we've only used
bandages, yes.
And although there has been very little published data on this, but recently in our study called data study, which I presented at TCT this year, this was a study on distal radial versus right radial access, and we used the gauze ball bandage in both of them.
Yes.
And the occlusion rate, radial artery occlusion rate, is just about 3%, which is same as what was there using patent hemostasis in the Prophet 2 study.
Yes.
So I think it works well, and in our setup it's very difficult to do a patent hemostasis, because it's very labor intensive.
Yes.
And I think if you just loosen it and you don't have the staff to watch it, then the risk of getting into a hematoma and compartment syndrome would be very high.
What about the amount of heparin to be used to prevent radial occlusions? Do you believe in that?
Yeah, the standard practice, what we've evolved, after the EVO study, is 5,000 heparin for all diagnostics for an average 70 kg person. In people who are less than 55 kgs or who are touching more than 80-85 kgs, and then we go by according to body weight, 70 units per kg. And for angioplasty, obviously it's ACT guided. In the primary setting, we would normally not give the full dose initially. There are two ways. Initially, we used to not give heparin till we had engaged the guide, because if you cross over on full dose heparin, if you had to cross over to the groin for some reason, because if you're wasting time, then the risk of hematoma would be much higher.
So coming back to this very important issue, because this is where now a lot of people keep asking that if you have an acute MI, are you going to do a radial or not? If you ask me, yes, all my acute MI PAMIs, we start with a radial. Unless the patient is in a cardiogenic shock and you cannot feel the radial, that's a different story. So we know that we clearly have a mortality benefit when you go transradial as compared to going transfemoral. So what started as just a little bit of a patient comfort oriented program, preventing back pains, preventing discomfort during passing urine, but now it has come to a point that transradial procedures in acute coronary syndromes and in acute MIs are known to be reducing the mortality rate as compared to the similar procedure when done to the transfemoral rate. So what do you say?
Yeah, I think absolutely true. And 2017, we actually did a survey at the NIC, and we were surprised to find that only 2% of the cardiologists were doing primary angioplasty. Even at Jaipur, people do a lot of diagnostic angiograms. Almost 30-40% would do elective angioplasty. But when it comes to doing primary angioplasty, it's only a very small number. And that is, I think, still the fear of a crossover, fear of failure, fear of delay. There is data now to say that if your door to balloon time does not exceed 20 minutes, more than 20 minutes over and above what you would normally take, it is still better to do a radial, because the mortality benefit is still there.
Right. So you brought out a very important point which I want to emphasize on, because many people feel that if you are doing a radial procedure, it's going to take you longer. I think there's a small learning curve where definitely you will take a longer time doing a transradial procedure compared to a femoral. But I guess if you are beyond, say, 20-25 cases doing a transradial, I think there is no significant difference between your procedure time if you are doing transradial versus transfemoral.
Yeah,
so I think that myth has to be...
We went through a publication in 2011. We did this consensus, which was published in JIMA. Job et al., Job and Tiffman, they wrote a paper on which and how should operators be graded in terms of increasing their complex cases, and so it would start with diagnostics, then go on to 1A, then go on to 1B, then go on to 1C, and once you are comfortable with the routine angioplasties, then you would go on to ACS. And so once you're comfortable with that, then you should take on primary angioplasty ST elevation, and then go on to the sicker ones, which is cardiogenic shock. So I think it's important that one should not embark on doing primaries right in the beginning of their practice, but once they are comfortable, and sometimes it can take years based on the number of cases people are doing. Sometimes it can take up to 10 years to become comfortable, and that is why I think the number of primaries is not that much right now with transradial access.
Well, I think the trend over here in Mumbai is slightly different, and I think most of the young guys who are trained now are radialists. In fact, we feel that they are much more comfortable doing radials rather than femorals, and I think so. So the trend for even doing primary angioplasty through radial is good in this part of the country or this city at least.
There's always been this debate about cardiogenic shock, and if you put a balloon pump, then should you be doing a radial or not, because you've already committed to the groin.
Yes.
But it has been our practice to do a radial even in patients who are on a balloon pump, and because of cardiogenic shock, because impella is hard to get, and because of cost issues. But again, the advantage of radial is there because the balloon pump comes off when the patient is stable, and by then the blood thinners have the effects have gone off. So it still makes sense to do radials in patients who are on a balloon pump and sicker ones.
So coming from the ACS and AMIs, what about the other subset of patients which have a complex lesion like a bifurcation lesion, and you need to do two stent techniques, or you have a CTO? So what kind of, are you able to do 7F procedures via the radial, and what about the newer sheets which are there?
Coming to complex PCI, we did the country's first transradial road ablation in 2002 using 7 French. But then the advantage is once you have the idea of size, if it's a 2.3 millimeter or more, then we've seen that there is not a problem because that translates into an equivalent French size. And if you had to go in a smaller artery, you'd probably better off going sheathless. But the problem is when you use sheathless guide, then you can't give any more deltaism if the patient goes into spasm, and if you have to change your guiding catheter, exchange it, then there's no way you can give deltaism if the patient goes into spasm. That's a problem with sheatless. And then now you have these slender sheets on which we've done a bunch of cases.
Yes, I was going to
with the Japanese, and we've done a bunch of chronic total occlusions using 5F, and it is feasible, and we actually published that in Indian Heart Journal as well.
Right. So Dr. Chugh is talking about the new slender sheath from Terumo, which actually, if you're using a 6 French sheath, you can put in a 7 French guide catheter through it, and that reduces your chances, and you can put you can do complex cases when you want to use a 7F in a person who has even a 1.8 millimeter radial artery. And Dr. Chugh has had a good experience with that, and I think this is the way it's going to be in the future.
So outside would be 5F, but inside would be 6F.
Yes,
so that's the big advantage.
Similarly for 6 and 7.
Yeah, but you have to be careful that because those kink easily.
Very slender sheets. So these are very slender sheets, and while you are exchanging your catheters and wires, you have to be really very careful doing it, because otherwise you can damage the sheath. But otherwise they seem to be a very good boon. Coming a little to doing some problematic radial cases. So what is your experience with patients having radial angulations and radial loops and subclavian tortuosities? What do you do?
This morning I did a talk on tips and tricks.
Yes.
And, so there are two things which came out. One is that we've now moved on to distal radial access, which is now our default access. And I presented, as I said...
So can you tell us a little bit about this?
Yeah, distal radial access is when you access the radial artery through the anatomical snuff box.
Yes.
And although you have more failures, there's again a learning curve, but even after 500 cases, we still have a failure rate of around 10 to 12%. And even then, even though the failure rate is little higher than when you compare that with the radial access, because here there are angulation issues, and the hand position is very important. If you don't have an appropriate hand position, which is a little bit of pronation with a little bit of extension at the wrist, then the alignment may not be good, and so your failure rate may be higher.
Right.
But if you do that, then even then the failure rate is like 10 to 12%. The puncture time may be higher. Radial artery occlusion rate may be same as that with radial access, But even then, hemostasis is easier,
easier.
because it's just a gauze ball bandage here, and there's no risk of a forearm. We did not have any forearm hematomas, though it can happen theoretically.
Right.
And so obviously the follow-up is not as labor intensive, and you don't have to do a patent hemostasis in that.
Right.
So that's an advantage of that. And if the radial artery occlusion rate is similar, then why not? So that's kind of become our default. And when it comes to crossing these tortuosities, our simple thing is, if you are in a hurry, meaning if it's a primary angioplasty, we would go with a angioplasty wire, which would make it easier to cross all of that, then use a balloon on top of that and use a guide which follows on the balloon, deflated balloon, not inflated, because with an inflated balloon it's defined as a bat, but we sort of don't attribute to bat because we think the risk of extravasation may be higher, risk of subsequent occlusion of radial artery may be higher. So with a deflated balloon, you can follow up on the guide on the wire and use the same wire and balloon to do your angioplasty. So it saves a lot of time and helps you negotiate these tortuosities and bends.
True. So we can go on about radial because there's so much to discuss, but we have some limitation of time. So, but I would like to make a couple of important things for the newer people who want to start doing radials. One question which I would like to ask, do you insist on an Allen's test to look for collaterals?
No, I've stopped doing
At least in the beginning of the career? What about the beginners? Should they do an Allen's or not?
Well,
I feel that they should do, but there are a lot of my colleagues who say they don't do it. So,
yeah, I think there's no harm in them doing the Allen's in the beginning part of the stage. But we've stopped doing Allen's. But clearly, if we've accessed the radial, we would not do the ulnar on that side, because that would be a hazard. Although there are case reports, but we would not recommend that.
And lastly, whenever you have a problem, though we have a lot of guides and catheters which can engage well from the radial procedure, but if you have a problem, I think one of the easy maneuvers which everyone should learn is to do a deep breath whenever there are a lot of tortuosities and kinks in the subclavians and all. A deep breath many a times helps to reduce the kinks and helps in improving the procedure outcomes. I think that's a very simple thing.
I think it's a very good
everyone should be aware of.
Coming to guides, I think you should use the guide you're comfortable with, even in your femoral. If it doesn't sit well, you can pass the wire into any branch that comes, if the guide's pointing towards the circumflex and you want to do LAD, pass your wire, soft wire into the circumflex or ramus, whichever comes first. And then you can turn the guide towards the LAD if that's your area of interest, and then the wire can actually go down there.
Perfect.
So that is a good way of using any guide, and buddy wires are useful for improving guide support. You can use additional support with a balloon also. So any case can be done using any guide, whichever you're comfortable with. It's best to increase your experience with the guides you're comfortable with rather than use fancy guides.
Right. So Dr. Chugh, to the end of it now, one last question. So in the last 20 years or so, you have seen radial evolve. So what do you say in the next 10 or 20 years? What do you think of the radial procedure? Where will we be in India?
See, I
will
think
it be the default mode?
It is already default for most people, but I think we are still awaiting data on the distal radial, and it's probably going to be time soon that people would think that distal would be considered better because of the ease of hemostasis and less risk of forearm hematoma. But while on this, I think we've missed out an important point, and which is it's very important when you do a radial through the standard radial access at the wrist, you must always keep feeling the forearm, not just looking at it, because a hematoma could be developing there. Sometimes we have a remote hematoma from a puncture from a wire, from a glide wire, by perforating a perforator somewhere. So that would be very important to keep feeling, and if you have any doubt, you should put the gauze balls along the length of the radial, cover that up with Dynaplast so that you prevent development of hematoma. That's very important. And if it starts developing, you have another way is to inflate a BP cuff, blood pressure cuff, sphygmomanometer cuff on the arm to above systolic, deflate every 3 minutes for 30 seconds, and so you can actually prevent the development progression of hematoma, which is very important if you want to prevent the compartment
That's
syndrome.
really a very nice tip for the beginners. Thank you so much, Dr. Chugh, for this discussion, and we can go on, but maybe sometime other, but there is a shortage of time. I think we've had a very good discussion. Thank you so much for coming.
Thank you.
Thank you.
Thank you.